The cardiovascular examination is where pathophysiology becomes visible, audible, and palpable, transforming abstract disease processes into concrete bedside findings. This is the cardiovascular clinical blueprint, a complete translation of what's happening inside a diseased heart into what a trained clinician can actually detect with their eyes, ears, and hands. We're going to move systematically through every component of the exam, from general inspection all the way to advanced ultrasound integration. Along the way, you'll learn to read pulse waveforms like a hemodynamic signature, decode the jugular venous pulse as a live readout of right atrial pressure, map every heart sound and murmur to its precise underlying valve pathology, and recognize the systemic signs of venous congestion and heart failure. This isn't just memorization, it's pattern recognition built on mechanism. Once you understand why a finding occurs, you'll never forget what it means. By the end of this breakdown, you'll be equipped to walk through a complete head-to-toe cardiovascular examination with the same systematic precision used in clinical practice worldwide.
Examination begins the moment you see the patient, before a single instrument touches their body. Overall habitus tells its own story. Cachexia and temporal wasting point toward advanced chronic heart failure. A Cushingoid or obese body habitus flags underlying metabolic syndrome. And a patient sitting upright using accessory muscles to breathe is signaling active decompensation right in front of you. Cyanosis adds another layer of information. Central cyanosis, seen at the lips and tongue, reflects inadequate arterial oxygenation itself, pointing towards cyanotic congenital heart disease, severe pulmonary disease, or a right-to-left shunt. Peripheral cyanosis, confined to the extremities while central mucosa stays pink, suggests reduced peripheral perfusion from low cardiac output or simple cold exposure. And differential cyanosis, a pink upper body paired with a cyanotic lower body, is a distinctive marker of a patent ductus arteriosus with reversed Eisenmenger physiology. Finally, don't overlook syndromic clues. Marfan syndrome brings arachnodactyly, pectus deformities, and a high-arched palate, carrying real aortic dissection risk, while Down syndrome flags atrioventricular septal defects, and Turner syndrome flags aortic coarctation and bicuspid valve.
The hands offer a remarkable amount of cardiovascular information in just a few seconds of examination. Temperature tells you about perfusion. Cool, clammy skin reflects sympathetically mediated vasoconstriction, commonly seen in shock or heart failure, while warm skin suggests adequate cardiac output. Capillary refill time, assessed by briefly compressing the nail bed, becomes prolonged when cardiac output is reduced or peripheral vasoconstriction is active. Nail deformities matter too. Clubbing flags chronic cyanic congenital heart disease or long-standing infective endocarditis, though splinter hemorrhages, while classically taught, are now recognized to have fairly limited modern diagnostic sensitivity. Speaking of endocarditis, two specific nodes deserve direct comparison. Osler's nodes are tender, raised, erythematous nodules on the pads of the fingers and toes caused by immune complex deposition. Janeway lesions are non-tender, hemorrhagic macules on the palms and soles caused by septic microembolism showering off an infected valve. And don't forget lipid markers. Tendon xanthomas on the extensor tendons and Achilles, along with xanthelasma around the eyelids, are visual red flags for familial hypercholesterolemia.
The arterial pulse waveform is essentially a hemodynamic fingerprint, and 5 distinct profiles let you diagnose valvular disease before you even reach for a stethoscope. Pulsus parvus et tardus shows a slow-rising, low-volume pulse, the signature of severe aortic stenosis, reflecting prolonged left ventricular ejection through a narrowed left ventricular ejection through a narrowed valve. The water hammer, or collapsing pulse, shows a rapid upstroke followed by an equally rapid descent, diagnostic of significant aortic regurgitation and its characteristic diastolic runoff. Pulsus bispherians shows 2 distinct palpable systolic peaks, found in combined aortic stenosis and regurgitation, or in hypertrophic obstructive cardiomyopathy. Pulsus alternans shows varying amplitude despite a perfectly regular rhythm,
a worrying sign of severe left ventricular systolic dysfunction. And pulsus paradoxus shows a systolic pressure drop exceeding 10 millimeters of mercury during inspiration, classically tied to cardiac tamponade, severe asthma, COPD, or constrictive pericarditis. Don't forget asymmetry checks either. Radial-radial delay suggests subclavian stenosis or aortic dissection, while radial-femoral delay is the classic bedside finding for aortic coarctation.
Blood pressure carries far more diagnostic information than a single number suggests, especially once you start examining pulse pressure, the gap between systolic and diastolic values. A widened pulse pressure reflects increased stroke volume or reduced arterial compliance, seen in aortic regurgitation, thyrotoxicosis, arteriovenous fistulas, anemia, and simple age-related arterial stiffening. A narrowed pulse pressure reflects reduced stroke volume, seen in severe aortic stenosis, cardiac tamponade, and low-output heart failure. Two other measurements carry significant clinical weight. Interarm blood pressure variance exceeding 10 to 15 millimeters of mercury systolic is a genuine red flag for subclavian artery stenosis, aortic coarctation, or aortic dissection, and should never be dismissed as measurement error. And orthostatic blood pressure thresholds, a drop of 20 millimeters of mercury systolic or 10 millimeters diastolic upon standing, measured at 1 and 3 minutes, are absolutely critical when evaluating syncope or presyncope, particularly in older adults or those on diuretic or vasoactive medications. These simple measurements often reveal serious pathology long before any imaging study is ordered.
Distinguishing the jugular venous pulse from the carotid pulse is a foundational examination skill, and getting it wrong leads to serious misdiagnoses. The internal jugular vein produces a biphasic, undulating waveform that is non-palpable, occludable with gentle pressure, and changes height with both position and respiration. The carotid artery, by contrast, produces a discrete single impulse that is palpable, non-occludable, and completely unaffected by position or breathing. Once correctly identified, the jugular venous pulse becomes a powerful, non-invasive estimate of central venous pressure, calculated as the vertical height of the visible pulsation above the sternal angle, plus an additional 5 centimeters to account for the distance to the right atrium. An elevated jugular venous pressure is a critical diagnostic flag, pointing toward right-sided heart failure, volume overload, cardiac tamponade, or constrictive pericarditis. Mastering this single distinction, jugular versus carotid, instantly upgrades the diagnostic value of every subsequent observation you make at the bedside.
Once you've correctly identified the jugular venous pulse, its waveform reveals an extraordinarily detailed hemodynamic story. The A wave reflects right atrial contraction. The C wave reflects the impact of tricuspid valve closure. The X descent reflects atrial relaxation. The V wave reflects atrial filling against a closed tricuspid valve against a closed tricuspid valve. And the Y descent reflects tricuspid valve opening with rapid right ventricular filling. Now, the pathology pop-outs. A prominent A wave suggests tricuspid stenosis, right ventricular hypertrophy, or pulmonary hypertension. A giant or cannon A wave indicates atrioventricular dissociation, the hallmark of complete heart block. An absent A wave means there's no coordinated atrial contraction at all, the signature of atrial fibrillation. And a prominent regurgitant CV wave points directly to severe tricuspid regurgitation. Two additional findings deserve special attention. Kussmaul's sign, a paradoxical rise in jugular pressure during inspiration, indicates constrictive pericarditis or right ventricular failure, while hepatojugular reflux, a sustained jugular pressure rise during right upper quadrant compression, indicates right heart failure or volume overload.
Moving to the chest itself, precordial palpation reveals 5 distinct apex beat patterns, each pointing toward a specific cardiac mechanism. A displaced apex beat, shifted laterally and inferiorly, suggests cardiomegaly from left ventricular dilation. A heaving, sustained, and forceful apex beat suggests left ventricular hypertrophy from chronic pressure overload, as seen in hypertension or aortic stenosis. A hyperdynamic, diffuse apex beat suggests volume overload, classically from mitral or aortic regurgitation. A tapping apex beat represents a palpable first heart sound, characteristic of mitral stenosis. And a double or triple impulse represents a palpable atrial wave or systolic bulge, a hallmark finding in hypertrophic obstructive cardiomyopathy. Beyond the apex, the parasternal region matters too. A parasternal heave, felt with the heel of the hand lifted off the chest wall, indicates right ventricular hypertrophy or enlargement, commonly from pulmonary hypertension or an atrial septal defect. And palpable thrills, a vibratory sensation of maximal turbulence, are typically found at the right upper sternal border in severe aortic stenosis, or the left lower sternal border in a ventricular septal defect.
Systematic auscultation relies on a precise anatomical map paired with an equally precise acoustic timeline. The aortic area sits at the right second intercostal space, the pulmonary area at the left second intercostal space, the tricuspid area at the left lower sternal border, and the mitral area directly at the cardiac apex. Now layer the timeline of heart sounds onto this map. S1 marks mitral and tricuspid valve closure, sounding loud in pliable mitral stenosis and soft in mitral regurgitation. S2 marks aortic and pulmonary valve closure, and its splitting pattern is diagnostically powerful. A physiological split shows normal inspiratory delay. A wide and fixed split, unaffected by respiration, signals an atrial septal defect. And a paradoxical split, audible specifically during expiration, signals left bundle branch block or severe aortic stenosis. S3, occurring in early diastole during rapid filling, denotes volume overload or heart failure in adults. And S4, occurring in late diastole, represents the atrial kick against a stiff ventricle, characteristically absent in atrial fibrillation due to lost coordinated atrial contraction.
Systolic murmurs each carry a distinctive diagnostic fingerprint across 4 dimensions: pathology, timing and quality, location and radiation, and response to dynamic maneuvers. Aortic stenosis produces a harsh, crescendo-decrescendo murmur radiating from the right second intercostal space to the carotids, and critically, it diminishes with Valsalva strain. Mitral regurgitation produces a holosystolic, blowing murmur traveling from the apex to the axilla, accentuated by left lateral positioning and hand grip, which increases afterload and regurgitant flow. Tricuspid regurgitation produces a holosystolic murmur at the left lower sternal border that increases specifically with inspiration, a finding known as Carvalho's sign, reflecting increased venous return to the right heart. A ventricular septal defect produces a harsh, holosystolic murmur at the left lower sternal border, frequently paired with a palpable thrill. And hypertrophic obstructive cardiomyopathy produces a systolic murmur that, unlike every other lesion on this list, actually increases with Valsalva or standing as preload drops, and decreases with squatting or hand grip, a distinction that frequently determines correct diagnosis on exams and at the bedside.
Diastolic and continuous murmurs round out the auscultation picture, each with its own unmistakable acoustic signature. Aortic regurgitation produces a high-pitched, decrescendo, blowing murmur at the left sternal border, best heard with the patient leaning forward in held expiration. Mitral stenosis produces a low-pitched, mid-diastolic rumble with presystolic accentuation, best heard at the apex in the left lateral position, and frequently precedes the development of atrial fibrillation due to chronic left atrial strain. And a patent ductus arteriosus produces a continuous, machinery-like murmur at the upper left sternal border or beneath the left clavicle, running uninterrupted through both systole and diastole. Beyond murmurs, several extracardiac acoustic phenomena deserve recognition. A pericardial friction rub sounds scratchy, high-pitched, and triphasic, best heard leaning forward in expiration, signaling pericarditis. An opening snap is a sharp, early diastolic sound following S2, representing a still mobile but stenotic mitral valve tensing as it opens. A pericardial knock signals sudden cessation of ventricular filling in constrictive pericarditis. And prosthetic valve clicks vary in quality depending on the specific valve type implanted.
Heart failure produces systemic markers that map directly onto specific anatomical modules, and reading these modules correctly tells you exactly which side of the heart is struggling. The pulmonary module, reflecting elevated left atrial pressure, includes bibasilar fine crackles, indicating pulmonary edema, and pleural effusions, detected through dullness to percussion and reduced breath sounds at the lung bases. The abdominal module, reflecting elevated right heart pressure, includes hepatomegaly, often tender from capsular stretch in acute right heart failure, a pulsatile liver, indicating significant tricuspid regurgitation, ascites from shifting dullness in advanced right heart failure or constriction, and an essential aortic risk check, since a pulsatile abdominal mass flags a potential abdominal aortic aneurysm. And the lower limb module includes peripheral edema, classically bilateral, symmetric, and pitting, worsening through the day with dependency and improving overnight with recumbency. Together, these three modules transform a routine physical exam into a precise hemodynamic map of exactly where the heart is failing.
Not all leg pathology is cardiac, and distinguishing arterial from venous insufficiency is a critical bedside skill that changes management entirely. Arterial insufficiency results from ischemia due to occluded inflow, producing pain at rest and intermittent claudication as key symptoms, pallor on elevation and dependent rubor as visual signs, loss of hair distribution and cool skin temperature, ulceration at pressure points or distal digits, and diminished or absent distal pulses with prolonged capillary refill. Venous insufficiency, by contrast, results from congestion due to failed outflow valves or pump function, producing aching, heaviness, and often unilateral edema as key symptoms, varicose veins and venous stasis dermatitis as visual signs, hyperpigmentation from hemosiderin staining, ulceration typically near the medial malleolus, and pulses that remain present, though sometimes obscured by overlying edema. Confusing these two conditions can lead to dangerously inappropriate treatment, since compression therapy that helps venous disease can actively worsen arterial ischemia, making this distinction far more than an academic exercise.
So, where does the classic cardiovascular examination stand in today's clinical practice? Some historical findings are genuinely fading in utility. Signs like Osler's nodes and Janeway lesions, once cornerstone teaching points, are becoming rarer simply because earlier disease detection means fewer patients ever progress to that late stage, though they remain valuable for pattern recognition and should never be entirely forgotten. Meanwhile, point-of-care ultrasound has emerged as a powerful complementary extension of the bedside exam, offering rapid estimation of left ventricular function, immediate detection of pericardial effusion, and inferior vena cava diameter analysis as a non-invasive surrogate for right atrial pressure. But here's the essential truth that hasn't changed. Despite this technological evolution, core hemodynamic skills, pulse characterization, jugular venous pulse analysis, and systematic auscultation remain absolutely indispensable. They dictate bedside triage and govern the rational, targeted use of every advanced imaging modality that follows. Master these fundamentals first, and every piece of technology you add afterward becomes exponentially more powerful. If this breakdown sharpened your clinical examination skills, please like, comment, share, and subscribe to Studious.